you, Tina, and thank you for the organizers giving me a possibility to tell about the systems and possibilities we have in Finland for the moment to use the aggregated data in quality improvement. I will shortly talk you about the definition, the need for aggregated data, methods we use to collect the data in Finland, and the use in the quality improvement. First, the definition. So with aggregate data, we mean the data that's combined from several measurements and several groups of observations and are replaced with summary statistics based on those observations. So actually, we don't need the personal data of these people if we work with aggregated data. My opinion is that you cannot really do continuous quality improvement without measuring, and that means that we have a continuous need for aggregated data if we want to work with quality improvement. We can do things with other methods as well to collect the problems and solve them and try to do better, but we actually don't know that we are doing better if we don't measure. It's good to remind us about an article by Scotch in the Journal of Internal Medicine where he went through the most effective strategies in improving the work in general practice, and those methods that you can get results that reach more than 10% increase in absolute appropriate care are mentioned here under. So the first is clinician-directed audit and feedback cycles. So it's important to know it's clinician-directed. If it's an administrator-directed, it will not reach the level. If there is no clinician directing it, it's only a feedback of numbers, it will not reach the 10% improvement level normally. Then we have the clinical decision support systems. We have specialty outreach programs, chronic disease management programs, continuous professional education based on interactive small group case discussions, and patient-mediated clinical reminders. So actually, only the first one is the one that's using aggregated data, and if you want to reach good results, you have to have an infrastructure where a clinician is trying to lead you to do better. So what does today take the Deming's quality circle and to make the good models, how to work in general practice, measure it, and especially to be able to make the statistical analysis. Is this change really a real change, or it just happening because of the small materials or so on? So we should be able to measure structures, processes, and outcomes, and all of us would like to have the outcomes because that's the real measurement. But to be honest, it's very seldom possible in general practice to have real outcome measures. So actually we are obliged to use all the time process measurement, and that means in the best cases we can find intermediate outcome measurements, or some people call them for surrogate outcomes. So give you an example later what this means, but to tell what the Finnish systems, there are several bodies that collect constantly information from healthcare that actually could be used for primary care quality improvement as well. We have the National Institute for Health and Welfare that calls hospital discharge register data. We have the Institute of Social Security that collects data on reimbursement of medicines. and we have census Finland that collects causes of death, and you can get this information on municipality level. In each municipality, the doctors can go and see how the hospital data is in different municipalities, and medicines and causes of death. Because the healthcare in Finland is organized by municipalities, this allows the doctors in the health centers to look at this data as well. And then there is a movement of Finnish quality networks where I'm part-time working with, who collects also annually data on major health problems like diabetes, blood pressure, coronary disease, risky use of alcohol, smoking, fracture prevention, and dementia. When we combine the data from the hospital discharge register and medicine register and Census Finland about deaths, you can make charts about real outcomes. And I have here an example of first coronary infarction with persons with diabetes in Finland. And you can follow the years. Here is 1994 as a 100 indicator year, and with the colors following each of the hospital districts, how they are doing, and going back 4 years from 94, you see that the colors are more red, which is worse. And when you move to 98 and 2002, you can see that the colors get yellow and green, and the more green, the better. So the red is 0.5 times the number of infarctions compared to the average in the country, 94, and the dark green is 0.5 times the number. So when you look at this, you can see that all the hospital districts are doing better, but you can find that some of them are really doing great work. You can see one of these hospital districts where the development is enormously fine, but you can also find districts where the development is not so great, or if there is any development at all. But for us as GPs, going back to these hospital regions, we really don't know, did I or did my health center do a good job in preventing infarctions in diabetic patients? Actually, the only place where you can see is the Helsinki district, which is one health center, where you can find the figures are getting a lot better during the years. So the doctors, GPs in Helsinki can take part of their work that I've been helping to get better. But inside Helsinki, there are about 25 to 30 different health centers. So in real life, each doctor cannot say, did I do better? Did my center do better or not? So as an example about the outcomes, coronary infarction, what we weight that for each 10,000 people, there are about 10 infarctions for a diabetic patient a year. And each one of us can understand that the variation is disturbing the analysis. So actually we should see a long time periods, 10 years probably, to see if there is any change in this indicator. So this is on the national level. We can get some information which is not very useful for looking at possibilities in primary care. Well, we have new emerging possibilities which come from the National Institute of Health, which has started recently to pick up the diagnosis and contents of health center visits of all nurses, all doctors in Finland. And this is in a way promising, but I'm not really sure this will result in a very good final result, because I'm not sure the GPs are want to fill in the diagnosis in a way that they should, and or the contents of the visits. And if they don't do that, it cannot be used as a quality improvement tool. Another emerging possibility is Duodecim's decision support system, which Ilkka is involved in and is coming into the new EQUI project, which we heard yesterday about. And this support system could collect, when it's collecting data for decision support, each time there's a patient in your room, the decision support system can tell you that according to the result, it looks like this patient has diabetes. You have not written the diagnosis. Do you agree? And then you can put in the diagnosis. And it can say that according to the risk profile, these patients should be using aspirin. Would you like to start aspirin for this patient? When it's making all these advices at the same time, collection of all these risk factors of diabetic patients could be collected to an aggregated database for quality improvement. So there's a really good emerging possibility for us in the future. Well, the Finnish Quality Network, where I'm involved in, is looking at those many different diseases, and our system is to look with samples. We take samples from patients, and that allows each health center to decide, do we want to do diabetes this year? Do we want to do smoking this year? And they don't have too much work for collecting data, and then if they collect, they do the whole quality cycle, not just the measurement part of it. It's a voluntary movement. About every third GP is participating, and because the GPs are working in large health centers in Finland, so this movement covers quite a lot of the country. To give an example what the quality network looks like in the diabetic patients, these are the indicators: coronary disease, written care plan, measurement of glucosylated hemoglobin, levels of glucosylated hemoglobin, LDL measurement, level of LDL, using statins, urine albumin measurement, urine albumin level, smoking, and blood pressure. And again, we know that the better the blood sugar level measured by H1 hemoglobin A1, the less we have coronary infarctions. So here again, we have a surrogate indicator to see, are we preventing coronary infarction, and so on. These samples, for instance, diabetes is 2 weeks. Every time there's a diabetic patient, the doctor fills in the formula that has some of the material. For tobacco, it's 3 days. For alcohol, 2 days. So it's not very much workload, but there is a workload in this process. And the GPs get back their results in the different scales, like you get the core indicators in this way, where the meter shows where you are placed, and it shows how you are doing, how your health center is doing compared to the others in the country. And you can quite fast look through the scale and see we are doing pretty well, except there and except there. And then the doctors can look at, okay, it's blood pressure patient smoking, we are not doing very good. Blood pressure, treatment of blood pressure patients, we are doing fairly good. Coronary patients smoking, we are not doing very good. Coronary patients, blood pressure, we are doing fine. We are doing fine with cholesterol. Smoking of diabetic patients, blood pressure of diabetic patients, cholesterol of diabetic patients, and so on, and the hemoglobin A1. So in a few seconds, the GPs in that health center say, okay, we are doing quite fine, except with the smoking. Shall we put our efforts for doing better in the smoking business in the future? And then they can go in, can you get me on this? We can go in, if they decide to do the quality measurement on smoking, they answer a few questions. We have this is very interactive all the time, the sample collection, to make it as simple as possible for the doctors. Can you push the marker for question number 4? And move down though. Yeah. Number 4. Yeah. And then, okay. It seemed it's dead for the moment, but when he answered that this patient is smoking daily, it will open up another 2 questions and ask, did you do anything today for this? You can answer nothing, or you can answer, I did this, this, and this. And this way they can get more information. Are we doing something compared to the other centers? Are we not doing? Our understanding about quality improvement in health centers is not that we cannot live only with the aggregated data from the patient journals, because there's so many things that are not structured. And if we want to be better, we have to know some details more how these people are doing. And this is the way we have solved the thing. Okay, can we go back to the presentation? And then the health centers, they get also reports how they are doing in a long run. They can get 5-year reports and compare themselves to the whole of the country. And in this way, they can put the effort and see where we are doing well and where we want to be better. And then they always get also the statistical analysis for the previous year and this year, and also the standard, the minimum, the goal with the red line, or the quality network has decided that cholesterol level should be good in 80% of the cases. And the dotted line, green line, shows where the best health center in the country is. So this kind of information they get for the work. So what do they do then? In the quality network, we have national coordinators who go into the health centers, help the doctors if they want. They go regionally, they collect the contact persons from these health centers once a year for meetings, and they do developing of the cure. And much of the care in the health centers with about 10 doctors is a system, looking at the systems, looking at the patient flow, looking at the way of working, looking what the nurses should do, what the GPs should do, and so on, in which order they should be doing. And this diagram is showing with the colors what the yellow is the nurse, the blue one is the doctor. The nurse has to do this and this and this before the patient goes to the doctor. And then the doctor does this and this, and some of the patients go only to the nurse if they are in good balance. And some other patients go very often to the doctor if we are trying to get them in a better balance. Can you go in here as well? Then the network keeps up, let's see if this is working. Can you go in the panel on that oppimiskeskus? This one, following, yeah. And then this one, yeah, go in there. Then we, if you scroll it down some more, we collect materials for the health centers, good process descriptions, good examples for patient leaflets, good advices for nurses, good advices for doctors, and so on. So each health center who is participating, they can go into the web, they can collect the patient leaflet, they can make their own logo on that, make changes in the text if they want to, and then they have the material. In this way, each health center does not have to work with this material all the time, but they have the material that's developed by the members of the network. Can we go back? So my conclusions are that the aggregated data collection is necessary if we want to have continuous quality improvement. Making collection automatic will help. In the future, with Ilkka's system, we will work in a way that when the questionnaire comes up to the doctor, the program asks, this is a diabetic patient, do you want to measure the quality now? And the doctor says yes. So after that, the system fills up the leaflet with all the information from the patient journal. And the doctor can go in and fill those questions that are not filled by the system directly. And also he can change. If there's old information about smoking and the doctor talks with the patient and he says, I'm smoking again, he can change that he's a smoker again and so on. Web samples will continue because we don't believe that the data that comes from the health patient journal only will be enough. Pop-ups will help in correction the data, and our strong belief is that quality does not improve without an infrastructure for improvement. Thank you very much.